A very warm welcome to everyone listening this session. I am Dr. Masood Khan. Our lung case history includes Arshad, 73-year farmer, male Muslim with no formal education and no known comorbids, admitted with OPD with presenting complaint of weakness of bilateral lower limbs 15 days and numbness of bilateral distal lower limbs since 15 days. According to the patient, he was in his usual state of health 15 days back, doing his daily activities normally. He suddenly noticed that his legs got weak. Slipping of chappals he noticed. He required a support to start his walk, especially he put a hand over shoulder of his caregiver. Weakness in both his lower limbs started at the same time. Since 5 days, he also noticed to have difficulty in standing from squatting position. No stiffness or heaviness of limbs he noticed. He is feeling numb till his ankles bilaterally. No history of pain, tingling sensation, burning pains. No history of gripping difficulty in upper limb or doing activities like combing of hairs. No history of numbness in upper limb. No history of orthopnea, neck holding. No history of bowel and bladder symptoms, any root pain. There is no history of backache or trauma at the back, any coryzal illness, and diarrhea before. Now we start that what are the causes of acute neurological disease like this. In neurology, the cutoff points for acute disease is 4 weeks, subacute is between 4 weeks to 8 weeks, and chronic is more than 8 weeks. While like stroke and CVA, it comes as a sudden event. So causes of neurological disease less than 4 weeks, that is acute causes, includes vascular cause and demyelination. Causes of subacute diseases, it includes infection and space occupying lesion. So stroke is sudden, and it is even we call it hyperacute. So in neurology, based on the history of this patient, in which there is distal weakness of 15 days and neuropathy like numbness, sensory neuropathy since 15 days. Now, there is no history of heaviness of the limb or stiffness of the limb. So this patient comes under the heading of lower motor neuron lesion, while upper motor neuron lesion are always distal dominant in limbs. So distal dominant, they are distal onset. There are certain rules or predominance. Neuropathies also involve distal involvement, while the lower motor neuron disease are always proximal in limbs, and but there are certain exceptions like anterior horn cell disease that lead with radicular pain in case of radiculopathy, then the muscle involvement, myopathy, then neuromuscular junction involvement. So in this case, there is no neuropathy in anterior horn cell demyelination. Another exception is GBS, demyelination of radicals. That's why it is proximal, because that's why it is called acute uh, demyelinating uh, radiculopathy. So this was a discussion of history and the relative terms and questions. Now in this case, history of distal weakness. Slipping of chappal indicates like what? It involves the extensor ollicis longus and the distal muscle groups, extensor digitorum longus. They are responsible for holding the chappal. So when there is motor weakness, the patient is unable to hold chappal and there is slipping. While if there is buckling of the knees, involvement of which group of muscles? The quadriceps weakness shows buckling of the knees. To get up from squatting position, which he later on developed. So this involves the gluteus medius, minimus, maximus and iliopsoas. These are the proximal muscles in the lower limb. No heaviness of limb. Now heaviness occurs or stiffness occurs in upper motor neuron lesions, and therefore it is a lower motor neuron lesion or a neuropathy. Why it is not a muscle disease rather than neuromuscular junction disease? Neuromuscular junction disease are associated with fatigability like myasthenia gravis, which on repeated tasks doing, after that there is fatigability, while Eaton-Lambert syndrome, uh, there is involvement of sensory involvement, but it is because of paraneoplastic uh, characteristic of Eaton-Lambert. Muscle diseases are always proximal. Radiculopathy is proximal, but radiculopathy is asymmetrical, sharp shooting pain over the trajectory of the nerve. Now in anterior horn cell disease, it is also proximal, pure motor, and there is florid vesting and fasciculation and long-standing history of anterior horn cell disease. There is no sensory symptom in case of anterior horn cell disease. Now on further discussion, there is a chronic neuropathy with autonomic dysfunction. Diabetes mellitus comes in this heading. HIV neuropathy can present as chronic neuropathy or acute neuropathy. While in case of acute neuropathy with autonomic dysfunction, GBS is on the top, porphyria, especially in young females. And there was another term, the head leg or the broken neck. Is the patient able to hold his neck? Now these are certain conditions in which there is broken neck syndrome. The Guillain-Barré syndrome. Number 2, snake bites, especially by cobra and krait neurotoxic bites. Polymyositis is an autoimmune disease in which there is broken neck, and myasthenia gravis is another disease in which there is broken neck and the patient is not able to hold his neck. Botulinism in children, and in which there is now based on this history, what are we dealing with? So our only entity that is left is acute sensory motor neuropathy. Combined sensory and motor loss can occur, especially in spinal cord disease. But in spinal cord disease, the sensory neuropathy is that there is a certain uh, like dorsal column loss occurs, in which there is proprioception lost, joint position sense is lost, stereognosis is lost, while the lateral cord injury or loss, there is loss of pain and temperature. And plus spinal cord disease, there is bowel and bladder involvement. So this is not present in this patient. Neuropathies, they have some graded response like gloves and stocking pattern. The patient explains that 75% loss or 50% loss or 25% loss of the sensation. So this was all about today's history presentation. Thank you very much.